Good afternoon, everyone. Okay, so I first of all thank this forum Pathalumini for inviting me to give this lecture on approach to renal biopsy. Okay, so when a nephrologist is considering a renal biopsy, so the KDIGO guidelines say that except in a young child having nephrotic syndrome, where diagnosis of minimal change disease is almost certain, all other cases can do a renal biopsy. Okay, and there are separate criteria for each specific disease that is in detail by KDIGO. They have given guidelines. So you can get a renal biopsy for most of the renal disease. But I know in periphery it is difficult to get a renal biopsy because many nephrologists outside, what they find is when they ask their patient to do a renal biopsy, the patient is afraid of that and he will most probably will not come to the same nephrologist again and will go to nephrologist. So somewhat in the periphery, still renal biopsy is less common. So how this biopsy is done? There are various procedures. Where I got trained, we used to have the biopsy in the front position with assistance of USG. Usually an 18 gauge needle is used, maybe 16 gauge needle also. And one can directly see the biopsy piercing the lower pole of the kidney. And the residents at the institute, we used to we'll get this kind of course that is 1 to 2 centimeters in length, 2 or 3 cores. And we will look it in a dissecting microscope or even a ordinary microscope under 10x power. And we will identify these globular structures. You can see it's reddish and globular. And you can see something pale here also. So that is not reddish, that is also glomeruli. And so that are the glomeruli. We will count the number of glomeruli. And the medullary area will look like this. So why we need to count the glomeruli? Because we are going to process the specimen, divide the specimen into portions of for light microscopy, IF and EM. Something like EM is a very tedious process. Say it will take 10 to 15 days for regular processing of an EM. So it takes lot of manpower and resources. So we must be absolutely sure that the small portion we are cutting for a EM should be having the glomeruli. So our procedure was to cut, say we will take, this is a core, we will identify the glomeruli here. We will cut 1 or 2 glomeruli, a small core containing 1 or 2 glomeruli. Okay. Then large portion containing 4 or 5 glomeruli, we will preserve for IF. For IF. And it's also important that the small bits containing used for IF should be containing at least 4 or 5 glomeruli, because both of these techniques need lot of skill, manpower and resources. Both are costly, EM and IF, and important regarding patient. So what is rest, like we will preserve one core and a part of second core that is remaining, we would process it for LM. At Calicut Medical College, our practice for LM is like we regularly do the H&D stain at least for 2 slides, means like 8 to 10 sections maybe. We'll do PAS chain for every case, Mason trichrome for every case, JMS. And when needed, we will do other chains such as Congo red. And IF, we regularly do IgA, IgM, kappa, lambda, C3 and C1q. Okay. EM we are outsourcing. And when needed, we do ISC such as C4D, C4D, etc. So this is our regular tray containing the renal sections. And it's mandatory that renal biopsy, all these change should be done. Otherwise, it is easy to miss various findings. So in renal biopsy, it is very important to have a proper request form. Okay, because our diagnosis is largely dependent upon clinical history.
അതന്നെ എന്തൊക്കെ കുഴപ്പം
So let us just rush through various factors of clinical history like age. Uh, various diseases have their occurrences in various age groups. For example, if I am receiving an nephrotic syndrome from a child, the most probable diagnosis would be minimal chain disease. If I am dealing with a nephrotic syndrome in an adult, most probably I will be dealing with maybe membranous, maybe an amyloidosis or FSGS. So various renal diseases have various age group patterns. Gender, there are differences regarding gender also, like for example, something like an SLE, there is a large female predominance in presentation, and something like a membranous has a male predominance, and something like X-linked disease like Alport predominantly seen in male children. And it is important to look at the clinical history, like what all diseases the patients are having, any infection, autoimmune diseases, other illness, like any lung lesion the patient is having, any physical injury, any hematological condition like plasma cell neoplasms, any other metabolical diseases the patient is having. History is also a very important part of the history. Okay, so one of the most common villain regarding renal problems is NSAIDs. Okay, so one of our biopsies, say 1/4 of the biopsies may be in renal in diabetic cases, and we see that a large number of these patients take over the counter NSAIDs. Okay, maybe so for some pain, and that land these patients in trouble because their kidneys already compromised, and the superadded effect of these NSAIDs will result in much damage. Okay, so the history of something like CNI is very important. Some heavy metals, for example, recently in Calicut, we had some face cream or something which was used had contained arsenic. So many of these patients were presenting with membranous nephropathy. So finally, and what is the clinician thinking of the renal condition? That is also very important. And we should be asking whether the biopsy is a transplant or a native biopsy. Okay. If it is a transplant, we should certainly know the CNI levels and any donor specific antibody, what is the levels. Why it is important? Okay, so this renal biopsy, somebody sees it, they will tell this is the MPGN pattern. Okay, so pattern is only one part of the biopsy. So this is what is called as a transplant glomerulopathy. Okay, if I am not knowing the history of transplant, I am going to call it as an MPGN pattern. If the patient is having hypertension, the patient can have hypertensive nephrosclerosis, and it can have very aggressive manifestation like the accelerated hypertension, and all the renal diseases can in turn produce hypertension. And one of the most common presentation that we see here are young patients, 30-40-year-old patients presenting with hypertension. When investigated, they would be having IgA nephropathy. Okay, so the history of hypertension is of very much importance. And some history when we get it, that is can give the clue to diagnosis. For example, if I am getting an elderly patient, say 70, 80-year-old person, having nephrotic range proteinuria, recently developed, also having hypotension, then I believe the most probable diagnosis from my side would be amyloidosis. Okay, because amyloid will co-deposit in the deposit in the heart also and will produce hypotension. And something like acute tubular injury may be caused due to episodes of hypotension. RBS, the blood sugar levels, it is absolutely important to know. Say something like this kind of a pattern. If the patient is having diabetes, diagnosis is very easy. If the resident is telling that patient is having no history of diabetes, then it's going to be a nightmare for the pathologist. The request form also contains details like the size of the kidney. Okay, so some normal size is some 11 to 12 into 5 into say 2 to 3. We should have a rough idea of that. All the chronic renal disease, there will be shrunken kidneys with diffuse increase in the echo texture with no corticomedullary differentiation. And some diseases like, for example, amyloidosis. Again, you have increase in the size of the kidney. Okay, another clue for amyloidosis is increase in the size of the kidney. Another very important area is the urine proteins. Okay, so daily about 180 liters of primary filtrate is coming out of the kidneys, and of the primary filtrate, it is amazing that only even the primary filtrate contains only 1 gram of protein, and the urinary excretion in a normal person is usually less than 150 milligram per day. Okay. So a lot of things are depend upon this particular history. Like if you are having proteinuria more than 3.5 gram per day in an adult, okay, or the other thing is a protein creatine ratio that almost run parallel to the 24-hour proteinuria. But the levels are say they are telling that usually the UPCR if you are taken from the early morning sample, usual. You can take it random also. So the early morning sample, the supine proteinuria, like not supine, the postural proteinuria, effect of proteinuria will not be there. So the gradient for nephrotic syndrome is slightly lessened in UPCR. So they keep it like 3 grams. Okay. And along with that, children, it depends upon the weight and height of the child. It is 40 milligram per meter square. Along with this, patient is having hypoalbuminemia, edema, hyperlipidemia, then we are going to call it nephrotic syndrome. Okay. And if they are not having these symptoms like hypoalbuminemia, hyperlipidemia, then it is only nephrotic range proteinuria. And then you can have the non-nephrotic range proteinuria or subnephrotic, in which it is less than that 3.5 grams. So this is just going to the KDIGO guideline. KDIGO always suggests that the 24-hour urine protein assessment is much better than, slightly better than the UPCR whenever possible. Okay, whenever possible, 24-hour is slightly better than the UPCR because it negates your circadian rhythm, exercise, night, day, everything. It will balance. But some conditions you may be only, like pediatric cases, you may be only able to get the UPCR. Okay, only spot may be possible. Okay. So UPCR came up from the idea that is a 24-hour collection is cumbersome. Okay. And why creatine is taken for the ratio, creatine excretion is fixed for a person. And it doesn't vary. For example, if you are taking the urine albumin or protein concentration, it can vary depend upon the hydration. Like you may get, if the patient is taking less amount of water, you may get a 3 plus. If you're taking a lot of water, you may get a trace. Okay. So you want to nullify such effects, and it is simple. So I think we have already gone through this. The what are the limitations? Like protein can have variation according to exercise, posture that we have already discussed. And see, creatine, the most important factor that in which the creatine is dependent is the body muscle mass. Okay, so you know that the male should be having more muscle, female would be having less muscle, and some patient who is emaciated due to disease may be having less muscle. Okay, so all these factors can affect your UPCR. He said that albuminuria is slightly better in assessment when compared to total proteinuria. Okay, and you certainly know that there is something called as microalbuminuria. And this is only to underline the importance of protein assessment in the severity of the disease. See, what are the most important two factors in the prognosis of the patient? See, one is the proteinuria, the other is the GFR. Okay, so it is so important regarding the status of the kidney. And you are going to get a lot of different terminology like complete remission, partial remission, relapse, steroid dependent, CNI dependent. Everything is going up, depend upon proteinuria. Now coming to very important topic, urine microscopy. Okay, I think it's not given much important in our scenario, but I believe it is very important. Like we should be, how we are going to give the report, like we should count the number of cars in 10 to 15 low power fields, WBC, RBC in 10 to 15 high power fields. Okay, and look at the crystals. So we are having the TAM Holmes-Wall protein secreted by the ascending loop of Henle. And whenever you are having the WBCs, RBCs, or tubular epithelial cells, debris, everything coming out, it get embedded into the this TAM Holmes-Wall protein and form the cast. Okay, so you can get the various kinds of cast like RBC cast, WBC cast, granular cast, okay, hyaline cast. So in a normal individual, you can get one or two hyaline casts in 10 to 15. Like it would be very low. And uh, you can get casts with fat in patients having only like a minimal change kind of a disease. Okay. Whenever you are having a lot of cells in the cast, you are going to call it a cellular cast. Okay. And when a cellular cast remains in the tubule for some time, the cells degenerate. Okay, cells degenerate and then they form the first the cellular to coarse granular cast, then they will form the coarse granular, then fine granular cast. Okay, so that is the natural progression of the cast. And finally, they will form the granular to waxy cast. And finally, the waxy cast. You may think waxy cast may be looking like a hyaline cast. No, it is more thicker, will have acute, like sharp edges and will kind of shiny in appearance. Okay. So why we need to know this progression? I think it is important because, okay, let us see this microscopic. What do you think this cast is? You are seeing clearly seeing cellular outlines. Yes, this is a cellular cast. Okay. And what is in the background? Lot of WBCs are there. So what is the diagnosis? There is only one diagnosis. Acute pyelonephritis. Okay, because I cannot have a cellular cast like this containing lot of WBC from anywhere other than the kidney. I cannot explain this. Okay, so if I am having this kind of a cast with a lot of pus cells, there is only one diagnosis: acute pyelonephritis. And suppose I am dealing with a patient having SLE. Okay, if the urine report goes on saying that you are having this kind of a waxy cast and or some say 3 to 4 or 4 to 5 granular cast. Okay, so in the back of my mind, I know that this disease is not at the active phase. Okay, I'm not expecting it's having a cellular component, but at the present point of time, it is not having an active like disease. This is not in peak. Okay, when I am having a SLE case with a lot of cellular cast, then I certainly know that this is having disease activities going on. And suppose if I am seeing a renal biopsy and I am seeing glomeruli, only few glomeruli, say pattern 5, the class 5, and I am seeing cellular cast, I should think again and again before signing out the report, because I am highly likely that I will be going wrong. I should be taking more sections. So I think the urine is actually a liquid biopsy. Okay, liquid biopsy which help us to assess the status of the kidney at the point of time. So I think I have explained all these things. And regarding the RBC, there is a concept called as dysmorphic RBCs. Okay, so these are having various dysmorphic shapes, like the different names are there, like Mickey Mouse, like donuts, G1, G2, different names are there. So dysmorphic RBCs, the different authorities have different opinion. Like there is a general consensus that if you are having 15 to 20 percentage of dysmorphic RBCs, like we are counting the RBCs, and 20 to 25% of them are dysmorphic, then it is highly likely that you are dealing with a hematuria that is glomerular in origin. Okay, you can have a hematuria even from the tip of urethra. Okay, that will not be dysmorphic like this. Okay, so if you are having a dysmorphic RBCs increase in number, you are highly likely that you are dealing with a glomerular origin of hematuria. Yeah, and the urine WBCs you can get in various origin, like from the glomeruli, like if you are having glomerular nephritis or pyelonephritis, cystitis, urethritis, in various different causes you can have increase in WBCs. And the last but not the least, crystals are very, very important. Okay, you can have the petal shaped uric acid crystals, or you can have the classical envelope shaped. Okay, calcium oxalate dihydrate or monohydrate can be tricky. It can look like RBCs or fan shape or dumbbell shape kind of shapes it can have. So why it is important to not to uh, like ignore the cause? Because I had seen cases in which there were no kidney biopsy was done in renal failure. Transplant was done, and within 2 to 3 months, the cause recurred, and the patient again went for renal failure. Okay, so you can have metabolic disorders, genetic metabolic disorders in the oxalate pathway, which can recur. Okay, there are many other causes also which can recur. So it is very important to look for the presence of cause. Another factor is the urine volume. Okay, so whenever the urine volume is less than 500 ml, you are going to call it oliguria. Anuria, some call it like near complete, no urine, or some call it less than 100 ml. Different definitions are there. Serum total protein. Okay, so normal is 6 to say 8.3, 8.5 grams, and albumin 3.5 to 5.5, and globulin 2 to 3.5. And why it is important? Because in nephrotic syndrome, you are going to have hypoalbuminemia. Okay, that is one factor. And something like if you are having something like plasma cell dysplasia, uh, this can, if you are having a AG reversal, that can give you a hint, okay, into the diagnosis. Already we have told about the hypercholesteremia regarding the nephrotic syndrome. Now, okay, coming to serum creatine, normal levels are, say, males 0.7 to 1.4, 0.6 to 1.3 in a female. Saying so, there are various factors involved in, including age and muscle mass. Okay. Age, say if I'm seeing a young patient with young, like say 10-year-old a 15-year-old boy with 1.4 serum creatine, then I will take it as abnormal. Okay, it should not be that high at that age group. There are variations like that, and something like muscle mass also has to be taken into account. For example, if a patient is emaciated, even an upper limit may be abnormal. Okay, so there are such factors also. And some levels like blood urea can give you some hint regarding the pathogenesis. Okay. For example, there are blood urea to serum creatine ratio is there. Okay. If the blood urea levels are very high when compared to like near normal or marginally elevated creatine, that suggests a pre-renal cause for the azotemia. Okay, a pre-renal cause, like a patient would have an accident or severe hypotension. That may be the most probable diagnosis. And there has been lot of other markers which has been described, like cystatin, NGAL, and its long list, but none has been as successful as creatine. Creatine is not a very sensitive marker for renal failure. Its level of serum creatine rises only if significant renal damage has already occurred. But still, it is only the best one and more reliable one available. So another important data that we will get is the complement levels. Okay, so various problems regarding the complement levels, like we can have the various activation of the classical pathway due to infections, or abnormal activation of the alternate pathway due to various mutations. Okay, regarding the alternate pathway. So various of the these problems lead to hypocomplementemia. Okay, so C3 level say 90 to 210 and C4 level 17 to 52. So look at this chart. If I am getting low C3 and C4 level, what should I expect? So this should be a problem that is related to the classical pathway. Okay, because of both the level C4 level and the C3 levels are low. So most likely there is something is going on in the classical pathway. And if I am getting only a low C3, then there is a possibility that I may be dealing with something, a problem in the alternate pathway. Okay. So that also gives us a hint. Okay. So various, you can see a whole lot of systemic diseases, infections, okay, autoimmune diseases can produce low C3 levels. And some data, some information we can get regarding from the CBC also. Okay. For example, any chronic renal patient may have like normocytic normochromic anemia. But if there is a sudden onset of renal failure, I am seeing anemia, then I will be a little concerned. Okay, like something like HUS can present like this. So suddenly I will look at the platelet levels also. Something like TMA can present like this. You can have a low hemoglobin as well as you can have low platelet count. Okay, then you will look for other things like what is happening in the peripheral smear or what is LDH level, D dimer. Like that, we can ask for more things. And a whole lot of serological test information may be very important. Like the patient may be having SLE or any different connective tissue disorder like scleroderma. Okay, or information regarding various other disease also very important. Something like ANCA. Okay. So at the end of the this assessment, you broadly reach in some endpoints. Like one is nephrotic syndrome. I think we have already described it. Okay, and there's a nephritic syndrome when the proteinuria is not in the nephrotic range and there is hematuria. Most likely the patient is having RBCs in the urine, cast also, and hypertension maybe. Okay, and another endpoint we may reach is the patient is having RPGN, rapidly progressive glomerulonephritis. It means the renal condition is failing within days or weeks. Okay. Another conclusion you may reach is patient is having asymptomatic hematuria or albuminuria. Okay. So this is a endpoint of our assessment of various of these factors. And you may also hear various other things like acute kidney injury, just means a rapid decline in GFR. Chronic kidney disease means it's like the kidney has permanently damaged. GFR is less than say 60 ml for at least a period of 3 months. Okay. And stage renal disease means the GFR is so low, less than 5% of the normal. Now we go into this thing like LM, IF, and EM. I am going to take you the journey together. Okay. So I'm not going into finer details of dissecting between the lesions, but I am trying to inculcate some thoughts in your mind, some way of thinking. Okay. So many of us would have heard a question regarding the adequacy of the biopsy. There is a general concept that something like 8 to 10 glomeruli are adequate. Okay, that's good, but see, there are more and more tests are coming daily. Something like, for example, there's something called as fibrillary glomerulopathy that requires a particular IHC called DNA JB9. Okay, if you are not having tissue for that, you cannot make that diagnosis. So your biopsy is inadequate. Okay. So, like if you are getting the LM, everything is okay. The diagnosis hangs on EM, the tissue is inadequate, then also you may not reach a proper diagnosis. Okay, and someone like Sanjeev Sethi is discovering new and new antigens and antibodies related to membranous nephropathy, and I think he has dissected some 10, 12 antibodies regarding membranous nephropathy. And what does it mean? You may need if a patient is having membranous nephropathy, he may need up to 10 IHCs. So the criteria for adequacy may vary from patient to patient. Okay, and something like if you are getting one glomeruli only and it is showing membranous nephropathy, I may be able to diagnose. But even the 10, like a patient is having nephrotic syndrome, FSGS is in question, 10 may not be adequate also. So the patterns are we can compare to our Navarasa concept in Indian classical art forms. Okay, so all the interaction with the world, worldly affairs will produce a rasa in your mind. Okay, and various same incident may have different rasa in different person. Okay, and within the individual also, the same incident may have different rasa at different time also. And there is something related to this pattern also. Suppose these are two persons. I sprinkle some pepper powder into their nose. See, both are reacting the same way. Okay. If I sprinkle some chili powder also, they are going to react the same way. But if I am going to hit their nose, they are going to react in entirely different way. Okay. So that is the reaction pattern. So regarding renal biopsies, I may tell, I think you can compare with old Malayalam movies. It's like the main actor may be Prime Nasir. So we like Satyan would be there, Sheila would be the Jaya Bharji. Okay, and the film will change. You can see all lot of films are there, but the actors would be almost same. Okay, like that we are having the endothelial cell, mesangial cell, epithelial cells, only few, all inflammatory cells, only few actors. Okay, and where the dance is happening, the place is also same. But you should look at the mudras, okay, to decide that the diagnosis. So this is just an example of just what I said, something like malaria. It can produce a lot of immune antibodies and can produce glomerulonephritis, can produce a lot of cytokines, okay, which can lead to tubular injury. And so it can present in various ways. Okay, same disease can produce various manifestations. So I'll tell most important chapter, some idea you should have is regarding inflammation and repair. Okay. So you know there is complement pathway, there is the alternate pathway, classical pathway, and there is a lectin pathway also. And these pathways result in the membrane attack complex, or it may produce C3A, C5A, which trigger the neutrophils, everything will come up on that area. Yeah. So if something is happening there, all your complement or various pathways are activated, and you know that the inflammatory cells are going to accumulate there. Okay. And the only other thing you want to know in this concept is there is something called as acute inflammation. Okay, you'll have a lot of inflammatory cells coming there, and most likely is going to resolve. And whenever you are having chronic inflammation, okay, you are most likely the thing is going for fibrosis. Okay, so this is a lower side. You can see a lung having pneumonia. Most likely it will recover. Okay, and the upper side you can having see can lung showing lot of fibrosis. Okay, so these are the two broad patterns regarding that we are going to carry forward. This is the most important picture regarding the glomeruli. Okay, see the internal you are seeing the fenestrated endothelium. Okay, you're seeing a lot of holes in that. This is the endothelium. Okay.
Hello,
Then comes the
Umasankarന്റെ presentation കാണുന്നില്ല കേട്ടോ. Not visible.
വിസിബിൾ ആണല്ലോ.
ഇവിടെ അല്ലല്ലോ, പക്ഷെ ഞാൻ ആണോ എന്താ ഉമാശങ്കറിനെ കാണാം, പക്ഷെ പ്രസന്റേഷൻ കാണുന്നില്ല.
ബാക്കി എല്ലാവർക്കും
കാണുന്നുണ്ട് കാണുന്നുണ്ട്
കാണുന്നുണ്ട്.
ആണുണ്ട്. അപ്പൊ എന്താ പ്രശ്നം?
എന്തെങ്കിലും നെറ്റ്വർക്ക് ഇഷ്യൂ ആയിരിക്കും.
ആയിരിക്കും. ഓക്കെ, പക്ഷേ നെറ്റ്വർക്ക് ഇഷ്യൂ ആണെങ്കിൽ ഉമാശങ്കറിനെ കാണാൻ പാടില്ല. കാണുന്നുണ്ട്, ഉമാശങ്കറിനെ കാണുന്നുണ്ട്, പക്ഷെ മറ്റെന്താ അറിയില്ല. എന്നാ കാര്യമാണ് കുഴപ്പമില്ല.
okay.
കാര്യമാണ്.
So this is the fenestrated endothelium layer you are having. See, tightly wrapping around the fenestrated endothelium, this thing is the basement membrane. Okay, and look at how the basement membrane is going. It is, see, when it is coming here, it is going over these mesangial cells into the next capillary loop. Okay, there is no basement membrane here. Okay, so the basement membrane is enveloping the fenestrated endothelium, and it just goes over the mesangial cells into the next loop. That means there is no basement membrane in this area. Okay, and over the basement membrane lies our visceral epithelial cell, the podocytes. Okay, their food processes are there over the basement membrane, and this is the parietal epithelial layer. Okay, and here in between the these capillaries are the mesangial cells. So we are going for the purpose of describing the disease. We are going to divide the glomeruli into two compartments. Okay, happenings that are going to be inside this basement membrane means inside this subendothelial space, this capillary, this mesangium, everything is one space. Okay, the boundary of that space is the basement membrane. Okay, and the things that are going to happen outside the basement membrane. Okay, I'm going to divide into happenings that are going to occur inside the basement membrane and outside the basement membrane. That includes the subepithelial space and the your food processes that is outside the basement membrane. So this is the same thing. If you look at the same EM picture, you can see this is a basement membrane going here, and it is just going over the mesangial cells like this into the adjacent capillary. Okay, so this is a common space that is available here. Okay, common space. This is again same, just to underline the same concept. So this is the entire area I am telling. This is the basal membrane coming over, going over the mesangial cells into the adjacent one. And it is like so this space is like a hand in glove kind of a arrangement. Okay, these capillaries are what are basically these are blood vessels only. These are capillaries only. Okay, they are dividing. They are enveloped by the these layers. Okay, this is the basic arrangement, and you can see here this is one space, common space. Yeah. See, the top is a top scene. Yeah. So now we are going to postulate some scenarios. Okay. Acute inflammatory response in the context of glomeruli. Okay. So I told you this is the common space that I am going to describe. This is the basal membrane, the subendothelial space. These are the fenestrated endothelium. These are the mesangial cells. Okay. This is I represent the food processes. Yeah. So something has happened like a infection somewhere in the body. Okay, you are having the antigen antibody complexes or complement getting deposited in this space. Okay, you can have deposited in the subendothelial space or in the mesangium. Okay, so it is getting deposited, sprinkled all over this space. Okay, and some may even occasional one may pierce out and go outside also. That is also a possibility. But most of them are in this space. So what will happen? You can tell what will happen whenever there are antigen, antibody, or complement. What will happen? You are going to have the influx of the inflammatory cells. Okay, you will have the neutrophil, macrophage, everything coming and occupying this space. Okay, they will try to clear up these dirty things that are deposited over there in the subendothelial space. Okay, also in the mesangial space. And look, this mesangium is also having many immune receptors. Okay, so they will also start multiplying. There is increase in the mesangial cells also. Okay, so you are having overall increase in cellularity in this compartment. That is called as a endocapillary hypercellularity and the mesangial hypercellularity. Okay, so these guys are very smart. So they are going to clean this, all these dirty things, complement, antibody, everything going to deposit it in this subendothelial space. Okay, and they are mostly very successful. Okay, they do their job very well. Okay, uh, and while doing their job very well, these guys are having some limitations also. Their boundary is the basal membrane. They can't jump outside the basal membrane. Okay, so something left maybe a few cell deposits in the mesangium. Let's say after 10 days or 20 days after the injury, we are looking like something may remain here or here in the mesangium. Something may remain. Okay, so exactly same we are going to, and in long run, even that would be cured. Okay, because it's an acute inflammation, and the usual response is you'll have a full recovery. Okay, so it's exactly same thing you are going to see in an IRGN. Okay, IRGN or called as a post-streptococcal, whatever acute infection you are having, some antigen antibody and complement get deposited in the area. So you are having you are seeing the endocapillary and mesangial hypercellularity. Okay, you can see all the capillary, all the glomerular enlarged, full of cells. Okay, and see you are having immune deposits, maybe C3, maybe IgG also. Okay, most commonly C3 along the capillaries. Okay, along the capillaries and also in the mesangium. Okay, also in the mesangium. So both of these figures, like this is called the garland pattern. This, if you are having more in the mesangium, then it's called a starry sky pattern. Okay, and you may get a like, okay, this is covering that. Like after say 10 days of the thing happening, or maybe 2 weeks or 3 weeks, slowly recovery also happens. Okay, so what you are going to get, this thing is mostly cleared. Okay, so you are seeing only mesangial hypercellularity that is remaining, but because it takes some more time for recovery on the mesangium. So you will get the mesangial dominant deposits, maybe C3. Okay, sometimes you may get IgG also. So this is the basis of the IF and LM pattern that you are going to see. Same thing you can see in the EM also. If you are seeing the acute phase, see, you are seeing whole lot of cells occupying the endocapillary space. Whole lot of cells you are going to see. And even at this low power, you can see these subepithelial humps. Okay, large deposits in the subepithelium. And if you are going to closely look, these arrows which are pointing is also very tiny deposits that are remaining in the subendothelial space. Okay, so this is the spectrum of features you are going to see in acute inflammatory response in a context of glomeruli. Okay, that we are going to call it IRGN or post-streptococcal, whatever you want to call. Okay, see, and if you are having lot of mesangial deposits in EM also, you will see lot of mesangial deposits at the electron dense deposits in the mesangium. Yeah. Now I am going to take, I think now we are inside that wall of the basal membrane only. We had an acute inflammation. Okay. So we are going to next scenario, another scenario. This is a scenario of IgA. Okay. IgA. So just in the basic understanding of the IgA pathology, IgA is nephropathy is caused due to some abnormal glycosylation of the IgA molecules. Okay, and antibodies are developed, like IgG antibodies are developed against this IgA, and both get deposited in the mesangium. Okay, that triggers the mesangial cell and inflammatory response. Okay, so this is a diagram that is telling the pathophysiology. We are having the IgA, that's the first increase in this kind of glycosylated IgA. That is first hit. Second is hit is production of IgG antibodies. Third hit is it is going to get deposit in the mesangium and trigger local inflammation. So see, the most, if you are getting the deposits in the mesangium, what is the most likely pattern I am going to get? See, I will get the mesangial pattern of the IgA deposition. If I am doing the EM also, I will see the electron dense deposits that are located inside the mesangium. Okay, you can see the electron dense deposits in the mesangium. We have already told that the space is not the mesangium and endocapillary are all same space. Okay, if something very fantastic happens in the mesangium, it will spill over into the endocapillary space also. Okay, if something very grand is occurring in the endocapillary space, it is going to spill over in the mesangial space also. Okay, so look at this IF. You can see very bright shining in the mesangial region IgA. Okay, but you are also seeing some staining along the capillaries. Okay, so if you look at the EM of such cases, you can see this is the mesangial region, and here you are seeing the electron dense deposits, and the same deposits are also getting somewhere into the subendothelial space. Okay, so you can now predict what is going to happen in the light microscopy. Mesangial hypercellularity already we are having. Okay, if something deposits are going to be there, like antibodies are there, complements are there in the subendothelial space, you should certainly get the inflammatory cells also there. Okay, so you will have the endocapillary hypercellularity. Okay, and we will after some time see the crescents also. You can have all the crescents also. Okay, so you can have various kind of this pattern in the same disease, same due to various of these factors. Okay, in the end of any renal disease, that segment of the glomeruli gets, if it is useless, it become chronic inflammation, that is sclerosed. Okay, it gets sclerosed. Means you will get FSGS, that is secondary. Okay, secondary to something primary like a IgA or MPGN pattern, whatever. And if it goes and goes for like, even you can get an MPGN pattern. Okay, let us go forward. Now, we'll go into a chronic inflammation scenario in terms of the glomerular capillary loop. Okay. So this is our capillary loop, and the patient is having a chronic disease like tuberculosis or say SLE. In our scenario, SLE is most common such disease. Okay. So you are going to have these antibodies complement everything getting deposited in the same space, subendothelial space and the mesangial. So these guys will come in, inflammatory cells will come in, okay, they will act and try to clear up the mess. But see, this thing doesn't end in one day, 1 week. No, it goes and on and on and on. Not only in the glomeruli, but in the entire body, it is going on. So at last, their cleaning becomes ineffective. Okay. At last, you are going to have a messed up area with lot of deposits in the subendothelial space remaining even after lot of time. So now our second inflammatory response kicks in. What is the second inflammatory response? Fibrosis means collagen deposition. Here, who is depositing the collagen? The basal membrane. Okay, so basal membrane is going to pack this mess. Okay, they just pack up this mess, you laying more collagen over it like this. Okay, so it may look like you are having a double contour or multi-contour. If you take a section of such a capillary loop, what you are going to see, there are multiple layers of the basal membrane. Okay, running, and the basal membrane is thickened. Okay, so this is exactly what you are going to see. Okay, you can see the basal membrane is having double contour. Here you see it is having multiple layers. Okay, so what is in between the layers? It is just clearing up the all the antibodies or complements what is getting deposited over there over time. Okay, and this creates this pattern. Okay, of membranoproliferative MPGN. Membrano means it indicates the thickening of the basal membrane. We have already described it. Proliferation also we have already described. Okay, so this creates the accentuation of the lobularity of the capillaries, which gives this characteristic appearance of the MPGN. Okay, so this electron microscopy shows the increase in cellularity, and you will see a lot of deposits in the subendothelial space, and even more clearly you can see this is one layer of basal membrane that is going, and this is another layer of basal membrane that's going. Okay, and see, look at this is the podocytes. Okay, podocytes is also not looking normal. You see, it is kind of flattened, and here I am seeing much Miller's formation also. So not only podocytes, see they are staying over a place where something really serious is happening beneath. Okay, like an earthquake is happening beneath, they will not be normal. When a disease is happening underneath for a long time, podocytes will also start showing signs of injury. Okay. So in IF, what will you see? You will have the deposition of what is the cause. Like if you are having a something like SLE, you will have all kinds of immunoglobulins deposited. Okay. If you are having something like C3 glomerulopathy, you will have complements deposited. Okay. So depending upon the IF, we are having the classification. Like if immunoglobulins are positive with or without your complements, then you are dealing with immune globulin mediated MPGN. You may be having like most probably autoimmune disease or maybe chronic infection, okay, or monoclonal, like you are having an multiple myeloma, something like that, okay. If the IF pattern is you are having only complements, okay, then most likely you are dealing with a some problem in your complement pathway. Okay, that may be related to various mutations in the complement pathway that produces inappropriate activation of the other pathway, alternate pathway. And if we are going to look such biopsies, we have already discussed this. The classical pathway will have complement and immunoglobulins. Alternate pathway, only complements will have. So if you are looking at the electron microscopy of complement mediated MPGNs only, okay, a portion of that will have thick ribbon-like electron-dense deposits along the basal membrane. Okay, like this, ribbon-like, very dense, very ribbon-like deposit, and some spherical or globoid, ovoid kind of deposit may be seen in the mesangium also. This is what is called as the dense deposit disease. Okay, so if you are seeing an MPGN pattern, the thing is very simple. Go back to your IF, see whether immunoglobulins are there. Then most likely you will be dealing with autoimmune disease infection or some monoclonal gammopathy. If the IF immunoglobulins are negative, you are dealing with a most likely dealing with a C3 glomerulopathy. You should correlate with the EM diagnosis. If dense deposit is seen, it's DDD. Otherwise, C3 glomerulonephropathy. And this also can, as I already told, all these can have multiple patterns. Like this also can have crescentic appearance. And finally, all these things can go for FSGS and global sclerosis. Now, breaking the barriers. Okay, so I don't know in this, yeah. So you can see ladies jumping, breaking the barriers. Okay, so it may breaking the barriers appears to be a fantastic idea, but what outside the lady doesn't know. Maybe she may be jumping from the 100th floor of some building. I don't know. Okay, so breaking barriers may not be a good idea. This thing is obstructing my, I don't know. See, what has happened here? This is the, yeah. So this is our capillary loop. It is broken. Okay. So remember, capillary loop is just another capillary. Okay. So you are having going. This is a EM of the same. What you are having? You are having going to have the bleeding of the blood into the space. Okay, urinary space. So when such a thing happens, okay, the fibrin that is getting outside, it is going to trigger the proliferation of the parietal epithelial cells, the visceral epithelial cells, and whenever the fibrin is there, a lot of inflammation is there, a lot of inflammatory cells will coming. So all of these things will form what is called as the crescent. Okay, so this response, when does a crescent happen? When there is a breakage in the capillary wall. How does a breakage happen? Because you are having all the inflammatory cells may be having elastase, collagenase, all those things. They can break the basal membrane. And also sometimes you may be having vasculitis. Okay, there are vasculitis which can produce the breakage. So whenever such a breakage happens, this is the result. You will have the crescent. So crescentic, we are going to call something crescentic glomerular. Crescent can be seen in various glomerulonephritis. We are going to call something as a crescentic glomerulonephritis if more than 50% of the glomeruli are showing crescents, okay, in number. And to call something as a crescent, at least 10% of the circumference should be having proliferation and at least more than 2 cell layer thickness. And when you are having crescentic glomerulonephritis, clinically the patient would be having what is called as RPGN, means rapidly proliferative glomerulonephritis. It means patient will deteriorate within days or weeks. Okay, patient would be on dialysis. So this is what you are going to see in crescentic glomerulonephritis. Okay, like a lot of crescents. Like there can be various types of slight differences in presentation of various crescentic glomerulonephritis. For example, in anti-GBM, okay, all the crescents would be in same phase. Means what? The crescents also has evolution. Like you have a cellular crescent, the fibrocellular crescent, and fibrous crescent. In anti-GBM, most likely scenario is that you can have all the crescents in one phase, cellular phase. Okay. Whereas other will have crescents in various phases. One would be in a cellular phase, two would be in a fibrocellular phase, and others in fibrous phase. So crescents are divided, crescentic glomerulonephritis is divided depending upon the immunofluorescent pattern. Okay. For some crescentic, the immunofluorescence would be looking like this, the linear pattern. Okay, means it would be just looking like somebody has drawn with a green fluorescent pen over there. Okay, it would be looking like that. And that is the linear pattern seen in anti-GBM. Antibodies are directed against the basement membrane. Okay, and the second pattern you will get as a regular all other glomerulonephritis, you will have the granular pattern along the capillary walls. Okay, granular pattern. Okay, so this would be supported by the endocapillary hypercellularity in the light microscopy and the subendothelial space having deposits in the EM. And there will be cases in which you may not get any deposits. Such cases are called post-immune because we are not getting any immune deposits. Okay, so this is a classification. You can have linear in anti-GBM, granular in immunoglobulin mediated, and the post-immune. So there are slight differences in histological appearance, some minor difference, like you can have necrotizing glomerulonephritis in like post-immune associated with ANCA. This also is necrotizing glomerulonephritis, same pictures. Okay, and also in anti-GBM, also you can get necrotizing glomerulonephritis. And these cases, you may also have evidence of vasculitis, both in anti-GBM and ANCA. You can get evidence of vasculitis in the interstitium also. Okay. Sometimes you may get granulomatous lesion vasculitis in ANCA-associated lesions. This is what is called as a medullary angiitis can be seen in ANCA-associated lesions. Yeah. Now we will go into our wall, that is a basement membrane. What happens when injury happens outside the basement membrane? So this is our basement membrane. Okay, this is lamina densa. Okay, then lamina rara interna, externa. So here is our subendothelial space. On top of this is our podocyte fruit processes. Okay, food processes. So we are going to think of some immune deposits in this region, subepithelial space. Okay, so most commonly these immune deposits target the membrane antigens in the podocyte membranes. Okay, so remember, our inflammatory cells can't go there. It's outside their boundary. So you will not have any endocapillary hypercellularity happening. Okay. And you are this is the first thing that you are having the antibodies targeting these antigens sitting over the podocyte membranes. Okay. You're going to get deposit in the subendothelial space. Okay. So here, again, our basal membrane try to envelop these antibodies. Okay, so it happens in stages. So it first starts as small outgrowths in areas. Okay, the first stage. First stage is just antibodies. Then small outgrowth starts. Then it will grow higher and kind of complete higher, and it will completely envelop. Okay, and finally it would be kind of resorbed. Okay, leading to vacant spaces. So it's the same thing happening in the EM. You can see small deposits. Okay, here and here you can see it's slightly larger. Slightly larger, and here your basal membrane has started growing into the deposits, and here it has almost enveloped. Okay, forming along the deposits, and lastly it will resorb the deposits. Okay, and IF you will see this most probably IgG and C3 along the capillary walls. You can get the granular positivity. So first stage, as I told, the glomerular capillary, we may not appreciate much of a change. Okay, and if somebody has seen many renal biopsies, he may appreciate that this glomeruli is looking slightly more beautiful or much better looking than a normal glomeruli. Okay, and this is a stage in which you get only the antibodies deposited in the subepithelial space, and this you can only pick up with the help of IF. Okay, you will get the deposits. In light microscopy, you will not see any change. But slowly, here and there, you can see small thickening has happened and small spikes have started appear, and it will in full blown phase, you will have diffuse thickening, and you will have all the bubbles, vacuoles, thickening. Okay, hair-like appearance. Okay, everything, spikes, everything happen. And sometimes you may be able to identify the fusionophilic deposits of the antibodies in the trichromes chain. Yeah, so that is about the membranous nephropathy. Okay, now going to an injury that is targeting the podocytes. Okay, so these podocytes are just sitting like octopus. Structure is something like an octopus. It will have this is cell body, secondary division, and from there the tertiary smaller divisions. Okay, so it is like a clasp of a hand. The adjacent food process would be from two different podocytes. Okay, so this is multicolored diagram shows that the adjacent food process of the zipper-like arrangement is from two different podocytes. So this is our filtration barrier, and we should remember that in a day about 180 liters of filtrate, only 1 gram of protein is just coming out the primary filtrate. So this filtration barrier is super effective. Okay, and this depends upon the size and shape selectivity of the GBM and slit diaphragm, etc. So it plays a very important role in keeping the large molecules like albumin inside. So this is a tree having lot of like nourishment, lot of water, everything, nourishment. It's having all the fineness. You will have the fineness like fine twigs, leaves, flowers, everything. Okay, but it's going to be summer. Okay, it will have all the it will lose all the complexities. It will lose its twigs, leaves, flowers, everything, and will look like this. Same thing happening in the podocytes. Okay, so we are going to discuss the injury that is going to happen in the podocytes. What all types of injury can happen? You can read about the different types of injury. It can be genetic, it can be various medications, it can be various cytokines. 100 different hypotheses are there. Okay, tumor necrosis factor, a lot of different things are there. That happens. Okay, so what will happen? You will lose the fineness of the structure of the podocytes. Okay, it will become attenuated. Okay, the fineness of the structure of the podocytes would be lost. Okay, and it will have, these are the fine microvilli. Okay, microvillus projections it will have. So this is how things should look. It will lose all its fineness. It will look like this, attenuated. Okay, and it will have microvilli and things like that. Okay, so that is your what minimal chain disease. Okay, the glomeruli is going to look as normal as possible in the LM. Okay, and you will have the attenuation of the food processes when you do the EM. Okay. So suppose the injury, whatever genetic or cytokine or whatever, goes on and on for much time. Okay, long time. Chronic injury happens to the podocytes. Okay, it's happening for long time. Then what happens? Cell death happens. Okay, podocytes are going to die. So what in effect you are having, this is a podocyte. See, all the podocytes here has gone. Okay, this area is bare. Okay, so whenever such two surfaces are bare in human body, what will happen? They will form synechia. So you can see the same thing will happen in the lung or in the pericardium or anywhere. Okay, when the surface pericardium or everything is gone, the two things will stick together. Okay, and this area become functionally useless. Functionally useless. Whichever area in the body is functionally useless, body is going to do cementing work there. It will put lot of collagen there. Area is sclerosed. Okay, so this is the end product of and result of this chronic injury to the podocytes. Okay, so this is the story of a group of disease called as podocytopathies. Okay, of the most prominent ones among the podocytopathies are the minimal chain disease and the focal segmental glomerulosclerosis. Okay, so if you are having only cell injury, you are going to call it minimal chain. You are getting the pattern minimal chain disease. If you are having cell death also, you are going to get segmental sclerosis, you are going to be called FSGS. So this is a synechia formation and this is a segmental sclerosis. Yeah, just another picture of the same in different chains. There are much rarer patterns like nodular glomerular sclerosis. I think it's beyond the time limit of this talk. Okay. So at the end of this discussing this glomerular pattern, I would like to tell again. See, this is data from Africa, where schistosomiasis is one of the most important cause of glomerulonephritis there. Okay, and see the patterns. It is producing all kinds of patterns: mesangial okay, membranous proliferative, amyloidosis, everything. Okay, so I think I had made the thing a little more clearer for you. How the same thing is producing different patterns. Yeah. Now I'll have to rush. Okay. So now we are going to the tubular interstitial compartment. So a normal tubular interstitial would be looking like this. Interstitial would be hardly visible. Only very little space. And you'll have this is a PCTs. Okay. This is a you'll have the can even see the cilia there in the PCT. A well-stained good section, you can even see the cilia. Okay. But whenever there is something tubular interstitial kind of injury happens, see how this just looks like somebody has beaten the tubules. All the tubules are kind of dilated. Okay, less colorful. See this entire area, you are not seeing any cell. Okay, the loss of epithelial cells in this entire area. Only one cell here. Okay, you are seeing cytoplasmic vacuolation. There are no cilia. Okay, this entire space is dilated. And you can see lots of these cells here, and these cells are kind of debris forming the cellular debris is formed in the lumen. Okay, that form the cast. Okay, even you can say in very active tubular regeneration, you can see the tubularization of the inside the Bowman's space also you may sometimes see. And when even the injury is more marked, like in this case, you can see the necrosis of the cells also. So these are the various spectrum of the tubular injury. You can even see mitotic figures in these cells. You may also come across some findings less frequently, like you can see myoglobin or hemoglobin cast, or like more frequent these days, bile pigment cast. We are seeing a lot of bile pigment cast in viral hepatitis A. You can see in this picture, these are the vacuolated tubular epithelial cells. What is causing vacuolation in these epithelial cells? Here we are seeing crystals. Okay, lot of crystals are seen. This is a case of oxalate crystals. And this is what is called as the isometric vacuolization. All the cells are having almost same kind of vacuoles. This can be seen in CNI toxicity and like some IV, if you are patient is having some IV fluids are given also, this kind of a picture you can get. And look at what you are seeing here, a lot of inflammatory cells inside the tubular epithelial cells in the lumen, also in the interstitium forming abscess, so pyelonephritis. Okay. And some disease like Sjogren's syndrome, scleroderma, and all, you may get a predominantly tubular interstitial pattern. Even though it is a autoimmune disease, you may get a predominant tubular interstitial pattern. You can see a lot of chronic inflammatory cells in the tubular interstitial space, and also fibrosis. Okay, so see how bad looking these tubules are. Okay, and look, just remember the initial picture that is shown, and just compare. Okay, so it's looking so small and very bad looking. So this is the tubular atrophy. Okay, and this blue thing in the fibrosis is the fibrosis. Usually, this picture is the fibrosis, the trichromes chain. Okay, so usually tubular atrophy and fibrosis go hand in hand. Tubular atrophy is various types are there. Okay, like tubular atrophy, best way is you look at the JMS chain or PS chain. You'll have the thickened and wrinkled basal membranes. Okay, thickened and wrinkled basal membranes, and the tubules will get smaller in size. There are various types of tubular atrophy also. Sometimes you get wrinkled, thickened like this. Sometimes you may get smaller. Okay, but it is not looking that bad. Maybe it's looking little beautiful also. This is an endocrine type of atrophy. Okay, this is just look like an endocrine, like your parathyroid sections. Okay, that is another type of atrophy. And then you can have atrophy like this. There's a thyroidization. The atrophic tubules dilated, filled with cast. Okay, and sometimes like in transplant scenario, you can get your virus also, BK virus also. You can go for the SV40 IHC also you can do. These are the inclusions that you are seeing here. Now going to the vessels. Okay. So looking at the vessels are important in some disease. Okay, something like hypertension and diabetes mellitus, you are going to get a lot of hyaline arteriolosclerosis. Okay, something like malignant hypertension, you are going to get this onion skin kind of appearance. Okay, and mucoid intimal change. Okay, if it is more pronounced, even you may get because this is the same onion skinning seen in the JMS chain, and in the lumen you are going to get the thrombus. Okay, so typical picture of accelerated hypertension. Thrombus can be very well seen in the trichromes chain. So this is a case of thrombotic microangiopathy. Okay, a primary thrombotic microangiopathy, most commonly some dysfunction in the C3 complement metabolism. So you can see the almost same kind of picture, onion skinning and the thrombus, and even the glomeruli, you can see the microthrombus, broken RBCs you can see, and this is what is called as a pseudo MPGN pattern. Okay, pseudo MPGN pattern in the thrombotic microangiopathy. Okay. So just winding up this topic, this is our renal team. Bindu madam is also there, but when we are taking this photo, madam was not there, was on leave. Thank our technicians also for the wonderful work they are doing, and also our very sincere PGs. And my first teacher, that is thank my Bindu madam. Then I attended the ISN online courses, the basic and advanced. And I think my concepts are largely based upon teachings of Dr. Vanessa Bijal. And I sincerely thank and adore Dr. Aruna Vanikar, who was my mentor at IKDRC, ITS at Ahmedabad, Gujarat. Okay. This was where we studied. And this is how it looks now. They do more than 350 transplant per year. Thank you.
Thank you much, Shankar. That was a very exhaustive and a very excellent way of introduction of renal pathology to the just entering pages. Very highly useful. Although I couldn't get all the slides, I couldn't see all the slides, but still I know how you have gone into the depths of the fundamentals of approach to renal biopsy. Thank you very much.
Thank you, sir.
Are you able to see my screen?
Yes, your screen is visible.
Yes.
Any problem with the audio?
No.
No.
Good afternoon, everybody. Myself, Dr. Nandini Singh from KMCT, presenting two rare cutaneous neoplasms. The first case is a 65-year-old female with a scalp swelling, and the skin did not show any ulceration. It was of 4 years duration. Ultrasound of the scalp showed a lobulated heteroechoic lesion with some focal vascularity. No deeper infiltration of the lesion was seen into the skull. FNAC was done on the scalp lesion, which showed loosely cohesive cell clusters, along with a lot of background mucinous material. On higher power, the cell group showed tumor cells which were small, monotonous, not much pleomorphism, and round to oval nuclei. We did a basic panel immunocytochemistry. Pan-CK was diffusely positive in the tumor cells, showing epithelial origin. P63 was also done, which came as negative. So with this, we thought of two possibilities. One is an adnexal neoplasm, and the second possibility was a metastatic carcinoma from elsewhere. And we advised excision of the scalp tumor along with clinical workup. This is the excision specimen that we received on the for this patient. It was a nodular swelling. The skin surface over the swelling was unremarkable. On cut section, it showed gravite areas, mucin-rich areas, also focal hemorrhage. The histopathology showed a dermal lesion. The epidermis was unremarkable. The lesion was fairly well circumscribed, and it had both cellular areas and mucin-rich areas. And the mucin was seen dissecting between the collagen bundles and the tumor cells. I'll show the hypa. This was a cellular area which showed the large lobules and sheets of tumor cells with some ductal differentiation, whereas the mucin-rich areas showed smaller lobules. On hypa, the tumor cell groups did not show much pleomorphism. There was focal ductal differentiation, and you can see the flat to cuboidal cells lining the ducts amidst the mucin poles. Again, not much pleomorphism. Mitosis was very scarce. So this 65-year-old lady, scalp swelling 4 years, with these histomorphological findings, we suggested two possibilities: metastasis from mucinous carcinoma, possibly origin of breast, GI tract, lung, or a primary mucinous carcinoma of the skin. We advised workup and we proceeded with IHC. IHC markers can be done to differentiate primary mucinous carcinoma of the skin versus metastasis to the skin. CK7 will be positive in primary cutaneous as well as metastasis. CK20, CDX2, beta-catenin, if they come positive, can help you towards a GI primary. ERPR, mammaglobin, GATA3 can be positive both in cutaneous, primary cutaneous mucinous carcinoma and in breast, so that they can have an overlap. So this is the variable panel that is generally done. So we proceeded with IHC, CK7 and 20. CK7 showed scattered positivity, CK20 was negative, and P63 came as negative. So CK20 negative ruled out a GI primary. ER was done, which showed a diffuse nuclear positivity, and synaptophysin was scattered positive. So with the CK20 negative and ER positive, we asked them to see if there are any lesions in the breast. Ultrasound mammogram of bilateral breast did not show any masses or suspicious calcification. CT thorax was also done, which did not show any mass lesion. So with the lobulated tumor, which was mucin-rich in the scalp, showing mucin-rich lesion with strong ER positivity, but clinical workup did not show any breast lesion, we came to a conclusion of a primary cutaneous mucinous carcinoma. Patient was advised to be on follow-up, and she is doing well. Primary cutaneous mucinous carcinoma was first described by Lennox in 1952, and there are around 380 to 400 cases reported. It is a low-grade malignant adnexal tumor of sweat gland origin. The original view was it was eccrine derived, and the contemporary view is that it could be apocrine. It shows a male predominance and it is seen in elderlies, middle-aged to older. Most lesions are head and neck, eyelid, periorbital, scalp is 17%, high recurrence. So the patient should be on follow-up. However, it has a very low metastatic potential. Histomorphology shows tumor cells floating in these islands of mucin. If there are precursor lesions seen adjacent to the main lesion, like ductal hyperplasia or carcinoma in situ, which is P63 positive, then it will help you to confirm a cutaneous origin. But we did P63 both in the cytochemistry and in the IHC, in the biopsy specimen, and ours came as negative. But even if P63 is negative, it doesn't rule out primary cutaneous. And the most important thing is that a clinical exam and a workup is essential because you don't want to miss a hidden primary sitting somewhere like that. The second case is a 27-year-old female, which is a smooth, firm nodular swelling over the right thigh of 2 years duration. And the skin over the surface was unremarkable. There was no pain or tenderness. It was a smooth nodular swelling, cut section gray white, no necrosis, some focal hemorrhage at some areas. But the histopathology showed these typical meningothelial whorls and some fascicles. And on higher bar, you can see the tumor cells have ovoid nuclei, not much pleomorphism, and occasional mitosis and no necrosis, no atypical features. The IHC showed a diffuse, tumor cells were diffusely positive for EMA, and SMA and S100 were negative. So with all these features, we came to a final conclusion of a cutaneous meningioma. Primary extracranial meningiomas are rare neoplasms which are slow growing, and they have a wide age range. The most common site is skin of the scalp. Ear and sinonasal are other sites. Lopez in 1974 has divided them into three. Type 1 is a congenital lesion, but it may be noticed later in life, and they occur in the scalp. And type 2 and type 3 are acquired lesions. The meningothelial type is the most common, and they originate from the arachnoid cell rest, which have been displaced during embryogenesis. Recurrences can be seen, so the patient should be followed up. Patients older than 40 years, if there is any necrosis in the lesion or an increased proliferation index, may have a more likelihood of recurrence. And very rarely they can die of the disease. For example, if it's an anaplastic or something like that. These are my references. I also would like to thank Dr. Sadi Madam and all the colleagues in my department for all the help rendered for this presentation. And I thank you so much, Pathalumni, for giving me the chance to present. Thank you so much.
Thank you, Dr. Nandini. Any queries from the audience?
Dr. Nandini, do you usually do immunocytochemistry for FNAs?
Normally we don't do, except സാധാരണ ചെയ്യാറില്ല മാഡം. പക്ഷെ നമുക്ക് എഡ്നെക്സൽ നിയോപ്ലാസ ആണോ എന്ന് അറിയണമായിരുന്നു. വലിയ പ്ലിയോമോഫിസ് ഒന്നും ഉണ്ടായിരുന്നില്ല. അങ്ങനെ നമ്മള് പിന്നെ എപ്പിത്തീലിയൽ ഒറിജിൻ ആണോ അങ്ങനെയൊക്കെ.
How does it, is it really useful?
Excision.
Meaning, how do you, when you take an FNA itself, you plan, you have to have unstained slides, isn't it?
What we do is, madam, for this case, we had many slides and we destained the slide and we did IHC on it.
Nina, no need for unstained slide. We do in even in effusion, sometimes pleural effusion and all, to differentiate between adenocarcinoma, and we do the IHC with FNA. From the Calicut onwards, we do.
No, we do cell blocks, madam. We do on cell blocks.
Yeah, cell block also in the smear as well we can do. It comes well.
Yes,
So you
FNA
destain
work
and then you destain and do the
FNA
IHC.
work ചെയ്യാറുണ്ട്.
FNA work
FNA
ചെയ്യാറുണ്ട്
work ചെയ്യാറുണ്ട്.
നന്നായിട്ട്.
You destain and then do the IHCs.
Yes, madam. Destain ചെയ്തിട്ട് ചെയ്യും.
So, how accurately can you give the diagnosis?
No problem. It comes well. നന്നായി വരും നീന.
Okay. Meaning like malignancies like pleural fluid and all,
To say it is adenocarcinoma, sometimes they will not be able to do the FNA or true cut in the lung.
So what
Adeno ആണോ അല്ലെ മെറ്റസ്റ്റേസിസ് ആണോ എന്നൊക്കെ നമ്മൾ നോക്കി
So what are the markers
CDX2
that you do on the pleural fluid?
അപ്പോൾ CDX2 TTF1 for example.
TTF1 comes out nice, huh?
നന്നായി വരുന്നുണ്ട്. എനി മാർക്ക് നമ്മൾ അവിടുന്ന് ചെയ്യാറുണ്ടല്ല സുപ്രിയ കാലിക്കറ്റിന് ചെയ്യാറുണ്ട് നമ്മള്.
It's not usually recommended, madam. അതുകൊണ്ടാ ചോദിച്ചേ. Meaning
recommended ചെയ്താൽ സ്റ്റാൻഡർഡൈസ് ചെയ്യാൻ കുറച്ച് പ്രയാസമുണ്ട്.
നന്നായി വരും.
Maybe for diagnosis alone, but then you can't do anything more on that. I can just say it is that. If it's a cell block, of course they can use it for molecular and all.
മോളിക്കുലാർ ഒന്നും പറ്റുണ്ടാവില്ല.
Just for the diagnosis.
ഈ സൈറ്റോകെറാറ്റിൻ തന്നെ നോക്കൂ, നല്ലതല്ലേ?
ബാക്ക്ഗ്രൗണ്ട് ഒന്നും പ്രശ്നമില്ല അല്ലേ?
അല്ല എന്ന് വെച്ചാൽ contaminants ഉണ്ടാവും, വേറെ different types of cells ഉണ്ടാവും. That's all we have to discriminate.
Madam, maybe you should have kept this as a future IAPM case, cytology.
അല്ല ഇതെല്ലാരും ചെയ്യുന്നുണ്ട്.
We don't do, madam. We don't do.
ആണോ? നമ്മൾ ചെയ്യാറുണ്ട്.
Okay, we can move to the next case. Next case from Baby Memorial Hospital. Dr. Shalini, junior resident, will be presenting the case. Shalini, you can share the PPT.
Next screen visible?
Yes.
Very good afternoon, and I'm present here. I'm Dr. Shalini, second year DNB resident from BMH. Today I'm going to present an unusual coexistence. This case was referred from outside hospital. Patient is 79 years old male. It came with complaints of cough and shortness of breath. He was a known case of diabetic mellitus on insulin. On investigation, which was done outside, hemoglobin was 5.8, total count elevated. Lymphocytes were 55%, platelets reduced, creatinine was elevated, albumin globulin ratio was reduced, globulin was elevated, serum calcium was within normal limits. Peripheral smear was done outside, which showed lymphocytosis with smudge cell. Serum protein electrophoresis was also done outside, which showed M-band in the gamma region with 6.2 grams per deciliter. Kappa and IgG was highly elevated, lambda reduced. X-ray skull was done outside, which showed bony lytic lesions. So their clinical diagnosis was multiple myeloma and chronic lymphocytic leukemia. We did peripheral smear, which shows RBCs showing rouleau formation, and there were predominant atypical lymphoid cells with clumped chromatin and increased smudge cell C. Here again we can see atypical lymphoid cells with clumped chromatin. Peripheral smear showed chronic lymphoproliferative disorder with rouleau formation. Bone marrow aspirate was also done, which showed atypical lymphoid cells with clumped chromatin, also showed plasma cells with eccentrically placed nuclei. Here again we can see plasma cells and the atypical lymphoid cells, here binucleated plasma cells. So bone marrow aspirate showed 49% of atypical lymphoid cells and 19% of plasma cells. Bone marrow biopsy was also done, which shows interstitial infiltration of atypical lymphoid cells. Here is the hyper view. Here under hyper view, we can see interstitial infiltration of plasma cells. Another view. And here we can see interstitial infiltration of atypical lymphoid cells. So at this point, our provisional diagnosis were lymphoplasmacytic lymphoma and a low-grade lymphoma with plasmacytic differentiation. So we proceeded with flow cytometry immunophenotyping on bone marrow. CD19 positive low site scattered cells, two population were identified. First, we focus on red cell population. This CD19 positive red cell population is showing kappa and lambda negativity. It is a CD19 positive. Here also we are focusing only on red cell population, which is showing concurrent positivity for CD23 and CD5. CD20 is dim positive and CD38 is negative. CD22 is also negative. FMC is negative. Again, red cell population is showing negativity for CD138. Red cell population is showing positivity for CD180 and bright positivity for CD200. And CD79B is negative. Here again, CD5 is positive for red cell population. This time we focus on blue cell population. Here, the blue cell population is showing kappa restriction and they are CD19 positive cells. They are showing negativity for CD23 and CD5. They are positive for CD20. They are negative for CD22. And they are CD38 positive, which means they are plasma cells. Again, they are positive for CD138. They are also showing positivity for CD200. And the blue cell population is positive for CD56. So summary of the immunophenotyping, there are two populations, that is CD19 positive B cells and CD19 positive plasma cells. This B cells, that is red population, was kappa and lambda negative, CD20 dim, CD5 positive, CD23, CD200 bright positive, CD19, 79B, 22, FMC 7 were negative, which shows immunophenotype of chronic lymphocytic leukemia. Those plasma cells, which are blue cell population, were kappa restricted, CD20, 38, CD138, CD56, and CD200, all were bright positive. So this immunophenotype shows multiple myeloma. With this, we gave the final diagnosis of multiple myeloma with coexistent CLL. On follow-up, the patient was treated for multiple myeloma and the patient succumbed to death 1 year after the diagnosis. This table explains our differential diagnosis of this case, which is lymphoplasmacytic lymphoma, chronic lymphocytic lymphoma with the plasmacytic differentiation, multiple myeloma with coexistent CLL. With clinical features, this lymphoplasmacytic lymphoma will be usually asymptomatic. They can have hyperviscosity syndrome, neuropathy, cryoglobulinemia when there is WM features are there. Then CLL plasmacytic differentiation, they will be having asymptomatic features or lymphadenopathy, splenomegaly, B symptoms. Multiple myeloma will have CRAB features. Biochemical parameters, all these malignancies will have cytopenia. IgM and serum protein electrophoresis can be maybe there or not, but in multiple myeloma, IgM is usually elevated and there will be M band in the serum electrophoresis. Immunophenotyping, B cells will be showing bright positivity for CD20, 19 and 22, 79B in case of lymphoplasmacytic lymphoma, and CD5, 23, 56 will be negative for B cells. In CLL, CD19, 5, 23, 43 and CD200 will be bright. CD20 will be dim. All pan-B markers will be negative. That is CD22, CD79B will be negative. FMC7 is also negative. In multiple myeloma, the B cells will be having the same features as that of this CLL. Plasma cells in the lymphoplasmacytic lymphoma will show CD19 positivity, but CD56 will be negative, and it will show the same restriction as that of the B cells, either kappa or lambda. It goes same with the CLL with plasmacytic differentiation. But in case of multiple myeloma with coexistent CLL, there will be CD19 negativity, CD56 will be positive, and there will be different light chain restriction from that of B cell restriction, as seen in our case. Then coming to the molecular diagnosis, lymphoplasmacytic lymphoma will have MYD88 mutation, CXCR4 mutation, and CLL with plasmacytic differentiation will have deletion of 13q, 11q, 17p, trisomy 12. And in multiple myeloma coexistent with CLL, we have CLL molecular diagnosis along with multiple myeloma molecular features such as IDH translocation, MYC rearrangements. With this molecular feature also, we can differentiate from each other. This is the article I read about this case. Concurrent diagnosis of multiple myeloma and CLL. They both arise from mature B cells in similar age groups. Coexistence is an uncommon event. So pathogenesis, according to Kozhikode et al., they are proposing two hypotheses. One is CLL tumor cells maturing to give rise to population of neoplastic plasma cells. In that case, it should show similar restriction in both B cells and plasma cells. In our case, it is not showing like that. The another hypothesis is two diseases could represent distinct clonal proliferation. This goes well with our case. Another journal saying CLL and multiple myeloma cells originates from same hematopoietic stem cell progenitor, different pro-B cell and oncocytic mutation occurred independently at different B cell differentiation stages. This makes more sense with our case. Treatment-wise, lymphoplasmacytic lymphoma and CLL with plasmacytoid differentiation, if the patient is asymptomatic, we can wait and watch, will do. In case of symptomatic patient, we have to do combined therapy. In case of multiple myeloma, the treatment totally differs from that of low-grade lymphomas, and the survival rate is also low. These are my references. Thank you.
Thank you, Dr. Shalini. Any questions from the audience?
The negativity in CLL that you got, that was your finding, no? What does it mean?
Ma'am, which one?
No, can you explain about your CLL population being both kappa and lambda negative?
Yes, ma'am. And there, this red cell population is B cell, which is negative for both kappa and both lambda. There is no restriction. But the plasma cells are kappa restricted. So which is different from the both population is showing different restriction.
Any other queries?
There was one more thing that you described I did not understand. You said in your literature workup in your table, you said multiple myeloma should have a different light chain restriction. What
Yes,
is
ma'am.
കടന്നുപോയി എന്ന് പറയാൻ കാരണം വെച്ചത്
B cell population, that
In
is
the table.
CL.
Go to table. On this. Oh, this.
Here, in case of lymphoplasmacytic lymphoma, the B cell, if the B cell is showing kappa restriction, means the plasma cell will also show the same restriction, that is kappa restriction. But in case of multiple myeloma with coexistent CLL, the B cell will show some other light chain restriction, and the plasma cell will show another restriction.
That point is understood. Different clonal populations. Okay.
Yes.
Okay, then. Thank you, Shalini. We will move to the next case. The last case is from Aster MIMS. Dr. Sharon Prasad will be presenting the case.
Am I audible, ma'am?
Yes, you can share the screen now.
Is it visible, ma'am?
Not yet. Now it's visible. You can change into slideshow mode. Okay. Now it's visible.
Okay, ma'am. Good afternoon, all. I am Dr. Sharon Prasad, DNB resident from Aster MIMS, Calicut, presenting a hybrid malignancy. So the clinical history, 71-year-old male presented to urology OPD with complaints of reduced urine outflow for past 3 months. On clinical examination, per rectal examination showed enlarged prostate gland and blood investigation showed mildly elevated PSA, that is 12 nanogram per ml. Imaging showed a heterogeneous contrast enhancement, possibly carcinoma prostate with extension into the bilateral seminal vesicle. MRI also showed this and proceeded with 3D laparoscopic radical prostatectomy. Grossly, we received a prostate gland with attached seminal vesicles. Prostate measured 5.5 into 3.7 into 3.5 centimeters and weighed 56.5 grams. PET section showed diffuse gray white areas with suspicious areas of multifocal extraprostatic extension. Microscopy showed a dual neoplasm in which cells were arranged diffusely and also in fused glandular and organoid pattern. Glandular areas showed cells having round vesicular nuclei, occasional distinct nucleoli, and moderate amount of cytoplasm. And the organoid areas showed
Excuse me, Sharon,
cells
your
have.
slide is not visible. Okay.
Okay.
Ah.
Organoid areas showed cells having round nuclei with stippled chromatin and scant cytoplasm. Disc mitosis was also seen. Intermixed areas were also noted. There were lymphovascular invasion and extensive perineural invasion. Bilateral seminal vesicles were involved by the tumor and multifocal extraprostatic extension were also noted. Proceeded with immunohistochemistry. Synaptophysin was done and it was positive in the organoid areas and it came out to be negative in the glandular areas. INSM1 was also done. It was also positive in the organoid areas. So we came to the diagnosis of small cell neuroendocrine carcinoma and acinar adenocarcinoma, conventional type with grade group 5, that is Gleason score 9. And the percentage of neuroendocrine carcinoma was approximately 70%. No non-pre-surgical therapy was taken by the patient. Both extraprostatic extension and bilateral seminal vesicle invasion were present. Both lymphovascular invasion and perineural invasion identified. Multifocal margin involvement was present and staged as PT3B. So small cell neuroendocrine carcinomas is a rare entity that may be pure or more commonly admixed with conventional acinar adenocarcinoma, and its incidence is 0.5 to 1%. More common in patients with metastatic disease subsequent to androgen receptor axis-targeted therapy for conventional acinar adenocarcinoma, that is, treatment-related neuroendocrine prostatic carcinoma. In our case, the patient has received no pre-surgical therapy. Shared TP53 gene mutation and TMPRS2 ERK fusion in mixed small cell and conventional acinar adenocarcinomas point at a clonal derivation of a common precursor cell. Urinary outflow obstruction is usually the first local symptom of small cell carcinoma of the prostate. Till now, only 12 case reports are there of this small cell neuroendocrine carcinoma of prostate. Among this, 4 were the mixed type. Bone metastatic disease or metastasis to lymph nodes or to visceral signs are usually seen associated with small cell neuroendocrine carcinoma, and paraneoplastic syndromes like Cushing's syndrome due to ectopic ACTH production, inappropriate secretion of antidiuretic hormone, or hypercalcemia due to excessive parathyroid hormone production, which is similar to small cell neuroendocrine carcinomas of other organ sites, can also be seen. Positive immunostaining for neuroendocrine markers like synaptophysin, INSM1, and chromogranin A can be seen in this. Grading is not applicable for the small cell neuroendocrine prostatic carcinoma. Only the acinar adenocarcinoma part is graded. Then in mixed carcinoma, the grade group of acinar adenocarcinoma component should be reported. And the treatment is platinum-based chemotherapy. These are my references. Thank you.
Thank you, Dr. Sharon. Any queries from the audience?
So what do they treat? Which carcinoma do they treat?
Ma'am, usually platinum-based chemotherapy is given, but nowadays trials are going on for a novel treatment strategy, including androgen deprivation therapy along with the chemotherapy. But the neuroendocrine part regression is rarely seen. It is only the acinar adenocarcinoma part is regression is seen.
So the question was, which carcinoma, usually if there is a neuroendocrine component, a high-grade neuroendocrine carcinoma component, they will always target that first. So what was the treatment given for this patient?
For this patient, platinum-based chemotherapy was given, but the
That is
patient
the-
lost a follow-up. An FDG PET scan was also suggested to rule out any metastatic lesion, but the patient lost a follow-up from the hospital.
So that is what I understand, because if there is a small cell carcinoma component anywhere, they will treat that first. And then only they consider the next part.
In this case, also approximately 70% were the new, small cell component.
So they would have given the platinum-based chemotherapy for that, isn't it?
Yes, ma'am.
Okay.
Usually for the other part, androgen deprivation therapy will be first given.
For the, okay. Okay.
Any other questions? If there are no more questions, we shall wind up the section. We will have the next meeting in the month of April. Thank you all.